Well, thanks, PMD Alliance, for hosting. It's nice to see everyone virtually. We're still, unfortunately, physically distanced, but socially connecting in this way, which we've, enjoyed. I think some great conversations and kind of leading into more of a mental health kind of bend, and some things that have been near and dear to my heart with wellness and things like yoga, meditation, mindfulness, things like that. So I'm excited to sort of put those two things together today and present a friend and colleague, Joel Mack. Dr. Mack is joining us from Portland now, but he's originally from part of the world that's near and dear to my heart, Buffalo, New York, which is just across the border from my hometown in Hamilton, Ontario, Canada. I see in the chat that there's people literally from all over the world. I saw somebody from Rome, some people from Australia. I don't even know what time it is in Australia these days, but yeah, so amazing to see all these people, lots of Canadians also. So a truly international audience here. So I'm excited. So Joel is somebody who really drinks some of the Kool-Aid that I do, which is, that these mind-body practices can really influence, the mind, but also the body, and are very helpful in Parkinson's disease. Joel is, like I said, from Buffalo. He did his medical school training there, and then moved out and spent some time at Hopkins, worked with Greg Pontone out there and Laura Marsh, who will be joining us at some point in this series. We'll refer you back to Greg Pontone's talk as well. That was really amazing to hear about his views on the mind and the body and the connection there. So, and now Joel is in Portland, and he works at the VA as well as at OHSU. And, we've had a lot of cool chats around the use of mindfulness and meditation in helping neurological diseases. So excited. Oh, wow. We have somebody from Ireland. That's really cool. So excited to have Joel join us today. Joel, welcome. Maybe tell us a little bit about your journey, how you ended up doing what you do, because we also share a love for music, and Joel DJs. He has a beautiful little daughter as well. And so, many of us are wearing many hats, but tell us how you got interested in this area of meditation and psychiatry and Parkinson's.
Hi, everyone. Thanks for having me. Thanks, Indu and PD Alliance folks. So I had probably through music and dance and things like that, even pre-medical school, I was kind of into the mind-body aspects of things. Even maybe before I realized it. And as part of the reason I went to medical school, I went into psychiatry and neurology, and during residency, I was looking to get involved in areas that were at that interface of sort of neurology, psychiatry, mind, body. And so Dr. Marsh, who you mentioned, was a mentor of mine and kind of brought me into the world of psychological, psychiatric aspects of Parkinson's disease, which was a great fit for that kind of approach, the mind-body approach. And so it kind of took off from there. And so I've spent the last 10 or so years of my career working with people with Parkinson's and on this stuff.
Awesome. So I know you put together some slides, and maybe I'll let you show those to us, and then we'll have a little bit of discussion. I'll monitor the chat and see if people have questions as well.
See if I can turn off the closed captions real quick. Let's see. All right, can people see my slides?
Mm-hmm. Perfect.
Okay. So as mentioned in the sort of intro, I'm going to talk today about psychological approaches and mindfulness, kind of from a psychiatrist perspective, working with people with Parkinson's. I think it's wonderful that resources like this have come about so that we can reach so many people from all over the world with a single talk. Although I will say I miss seeing people in person as well. And so along those lines, I'm going to sort of start off with just throwing a little scenario out there for you all. I want you to kind of envision this, and we'll kind of use it later on. Imagine that this talk is in person, and so you're going to see it in an auditorium where one might have before the pandemic. And so you get to the place where the talk is at, and you're running a little behind. It was tough to get going and get there. So you kind of get there right on time, and you walk in and you open the door, and it's a crowded auditorium. Seats are all filling up or filled up. So you're kind of looking around for seats, and it's a little bit anxiety provoking right off the bat to be walking in there. And so I'm going to start with just kind of having you think about that, and we'll come back to it later on with a little bit more detail. So I don't have any conflicts to disclose. So my goals today, a little bit of review if people have tuned in for prior talks, such as Dr. Pontone's, but I'm going to talk a little bit about neuropsychiatric symptoms, sort of taking a journalistic approach, the who, what, wheres, whens, whys, and hows of some of these things and psychological treatments. And then touch upon depression and anxiety, mainly to highlight them for context of how we use psychological interventions. Talk about what psychological interventions or psychotherapy or mindfulness are, and who and how they can benefit, and then just close with a little bit about sort of where to turn or who to talk to if you're experiencing some of these issues. So neuropsychiatric symptoms in Parkinson's are part of sort of a bigger umbrella term of non-motor symptoms. And non-motor symptoms, as we've learned over the years, can be some of the most problematic, even more so for some people than motor symptoms. Can include things like autonomic issues, so constipation, urinary symptoms, trouble with blood pressure, sleep disturbances, as well as other sensory issues, and then neuropsychiatric problems, which can include depression, anxiety, psychosis, which is hallucinations and delusions, impulse controlled issues with behaviors like gambling, compulsive sexual activity, or eating or buying, as well as it should also mention cognitive dysfunction or cognitive impairment on there. And so this is just to kind of give a broad overview and some context of the many non-motor symptoms people might experience, and kind of where what I'm going to talk about today fits in. This is a popular slide that some of you may have seen before, but it's kind of giving a typical progression of the different symptoms of Parkinson's disease, both motor and non-motor. And so I just wanted to kind of talk about where you might see depression or anxiety over the course of Parkinson's disease. And the simple answer is pretty much anywhere along the lines. We even know that depression and anxiety can be part of a premotor syndrome, so coming on even before the motor symptoms of Parkinson's disease in the 5 to 10 years beforehand, and then throughout the course of the illness. And sometimes things like anxiety problems later on can become more problematic in the setting of worsening motor symptoms or the treatments of Parkinson's disease, and I'm going to kind of talk a little bit more about that. This slide just speaks to kind of to the why people experience depression, anxiety, or apathy in Parkinson's disease. So one might think, or sometimes there's false thinking that, of course, people get depressed or anxious because they have Parkinson's or they have a chronic illness. But in Parkinson's, it actually goes above and beyond that. We see high rates of these psychiatric issues, and that's because the same circuits that are involved in motor function are also related to mood and cognition and some of these other aspects of disease. So just to kind of highlight that low dopamine, which is the problem for motor symptoms, and these same circuits can also affect your mood and lead to things like depression, anxiety, motivational issues, cognitive issues. So it's the actual brain changes as well that lead to these symptoms being so common. And then in Parkinson's disease, we have sort of this other specific aspect of the medication treatments. And I'm using anxiety throughout the talk again, sort of to review that aspect, but also just as an example as we get into some of the treatments. As we know, the main treatments, medication-wise, for Parkinson's are dopaminergic medications. And the goal is really to get a sort of smooth flow of dopaminergic medication so that it treats your movements, and you can stay in this sort of middle zone of having your movements addressed, but not having these peaks and valleys. Unfortunately, we know the medication works in sort of a peak and valley fashion. So has an onset and a peak, which sometimes can lead to hyperdopaminergic states. And these can cause motor issues like dyskinesias, but can also cause a lot of non-motor issues. So on the positive side, people might feel more relaxed or more easily engaged in pleasurable activities. Sometimes if it kind of goes too far, there can be hyperactivity or disinhibition or compulsive behaviors, or even sort of a manic state. On the flip side, when dopamine is low or off, that can lead to sort of feelings of cognitive dulling, depression, panic attacks, often associated with freezing of gait or some of the motor symptoms, and sadness and sort of a dysphoric or depressed state. And so I'm going to talk a bit about all of this in the context of how we help address it. So in terms of anxiety, generally, and in Parkinson's, we can see it present in a few different ways. Often anxiety is persistent or generalized. So this is sort of daily anxiety that's there most of the time throughout your day, may cause things like sleep disturbances or fatigue. And it's just sort of a generalized worry that people experience, which is a bit different than episodic anxiety, which often presents as panic attacks. So very intense, sudden spikes of terror or feelings of impending doom, a lot of physiological symptoms like rapid heartbeat, sweating, increased shaking might accompany it. And then there's avoidance anxiety. So this is often related to kind of social anxiety or developing fears about being in social situations or going out. As one has more severe motor symptoms, they may worry about things like their tremor while they're out at a restaurant, or having to make it to a bathroom, or that they're freezing and they're fearful that they're going to freeze, so they start to avoid these kinds of activities. Often we
I think Dr. Mack, his connection seems to have frozen. We'll send him a note via text and see if he can get back on. Oh, let's see. Okay. While we try to connect with Dr. Mack, Indu, anything to add in the meantime?
Yeah. So yeah, why don't we try to get him back online? So unfortunately, it's always a fun situation with the Zoom and the internet, but yeah, I was just really fascinated by actually the slides so far, because I think he's done a really good job of showing the dopamine sort of fluctuations, and also sort of these Venn diagrams of anxiety and the different symptoms are quite interesting to me. So I think there'll be a lot to explore in the question and answer and stuff like that. So stay tuned for a second. And somebody had asked about what kind of DJ Joel is. Yeah, he's a DJ of music, absolutely. And he's interested in, we'll have to ask him exactly what kinds of music. It's not hip hop. I like hip hop a little bit more than he does, but yes, and he had DJ'd for the first time, I think, in a park outside over in Portland on the weekend, and his daughter, who is a very cute little blonde thing, was dancing, and his wife posted a video. So I think the musical aspects are definitely inherited in that family. It's sweet. So yeah. So how's that? Have we been able to catch him? Because I can also try to touch base with him if you want.
Yeah, Kelly's working on it. And I think the comment that Polly put, that it's great to get to know the hobbies and all of these presenters as, actual humans with lives and passions. I think that's been important to kind of break down that white coat, ivory tower type barrier. So
yeah, absolutely. And we're actually, interestingly, I don't know, I really enjoy most of my colleagues. I would say 99.9% of them are people that I want to have at my house for dinner. And I've been very lucky to get to know them over the last several, I guess over 20 years of going to meetings, and we all look forward to seeing each other. And it's been fun to explore and support each other, I think. And part of the social connection is trying to figure out how to stay engaged. So I think this forum has been good as well. So, yeah, it says he's logging back in, so he should be with us in a moment. And one of the things that is interesting about May, so April was Parkinson Awareness Month, but May is actually Mental Health Awareness Month, and I've been trying to really highlight some of our colleagues who we haven't really had a chance to hear from in some of the sort of sessions in the past, and have some psychologists and psychiatrists reaching out and teaching us a little bit about what they do, because I just think that they're so gifted and they spend so much time with our patients and have really a different lens, but it's such a complementary lens. So I'm excited to continue the exploration of some of these topics, which I think a lot of people have been facing, especially given the pandemic. So I see that Joel is maybe back. I see that he's the co-host now. So
Can you hear me okay?
Yeah.
Okay. I'm terribly sorry. At the VA, the internet connection seems to be a little bit wonky lately. So hopefully that was the only touch. Thank you. Thank you.
And
There
I
we
think
go.
you cut out on the previous slide with the Venn diagram.
Okay. So the Venn diagram was I was highlighting, I don't know how far through it I got, and again, apologies. So this was highlighting different types of anxiety that people can experience. So, and 30 to 40% of people with Parkinson's will have anxiety at some point over the course of their illness. And this can be persistent anxiety, so sort of generalized anxiety, that's generalized worry that's there most days, most of the time, worries about the future, worries about finances, worries about illness, all of these things. Episodic anxiety, which is intense spikes, often typically panic attacks are called panic attacks, a lot of physiological symptoms, feelings of terror, fear, rapid heartbeat, sweating, shaking, sort of being frozen with fear, and then social anxiety. So this aspect we often see or can see later in illness course when there's worsening motor symptoms. People might be anxious about leaving the house, going to social functions where they might have more tremor. Things like trying to make it to a bathroom if somebody's having urinary issues or incontinence or anything like that can play into these, or fear of falling or freezing. And so people start to avoid situations because they're worried these things are going to happen. And often what we see is sort of people can develop anxiety about having anxiety. So they have a panic attack and they then worry about leaving the house again because they're fearful they're going to have another panic attack, and this can become quite debilitating. And often what we see is sort of a mixed picture of different aspects of each of these in Parkinson's. So this is a bit of a busy slide, and I won't go through it in too much depth, other than to say, in anxiety and in Parkinson's as well, there's sort of these different aspects, and this applies to depression as well. There's the emotional aspects, the cognitive aspects, behavioral aspects, and then especially in neurological diseases, you also have these physical or motor aspects that can play into these relationships, these cycles. And of course, all of these things occur in the environment. So for example, the pandemic has been very stressful and anxiety provoking for many people. Social interactions, medical appointments, finances, all of these things, it's the environment that one is in, experiencing these symptoms. So for example, cognitive aspects of anxiety can include negative ruminations. So just kind of cycles of worry that might affect falling asleep and take up a lot of your day. Often the worries are about the future or the past in this sense. Phobias, which are specific fears, trouble with concentration, fear of falling, fear that one is kind of losing control. And these play into also emotional aspects, so feeling nervous, fearful, irritable, embarrassed, and then there's kind of behavioral consequences of these things. So as I mentioned, starting to avoid certain situations, avoid social situations, maybe not leaving the home, which is also called agoraphobia, kind of escape behaviors, feeling like you need to get out of a situation or place, as well as compulsive or ritualistic behaviors, sleep disturbances, agitation, and then the myriad of physical and motor symptoms, worsening tremor or freezing gait, as well as some of the others that I mentioned. And I'm putting it in this format because this will come back up as we discuss some of the psychological interventions. And I'll try to be mindful of time given the little delay with the cutout. And then this slide is here just to kind of display also the effects of chronic stress. So chronic stress that comes with illness and in Parkinson's specifically. Stress causes changes in your glucocorticoid hormone system, things like cortisol, cause actual changes in the brain that can make you more susceptible to depression and anxiety, as well as possibly affect cell loss in the movement circuits in your brain, leading to more advanced disease. And of course, both of these things can kind of cycle back and increase chronic stress and continue that cycle. So this is a slide from a RISA paper by Dr. Pontone, and I will not go through it in too much detail, but it's a treatment algorithm for addressing anxiety and Parkinson's. There's a very similar one for depression, but looking at the box that's labeled Tier 1, it's essentially the first line treatments for anxiety and Parkinson's disease. And so one aspect of this is medication, which I'm not going to go into today, given the focus of the talk. But I am going to talk a little bit about behavioral activation and exercise, cognitive behavioral therapy, which is a specific psychotherapy approach it's probably the most well-studied psychological approach in Parkinson's and otherwise, as well as touch a little bit on some mindfulness-based therapies and kind of give a little bit of a primer. Won't have time to go into too much detail. And then also just to note at the bottom, these special situations that we've kind of covered in Parkinson's, things like non-motor fluctuations, fear of falling, the role that cognitive impairment or autonomic symptoms like your blood pressure dropping, lightheadedness, how they can all play into anxiety and be specifically addressed. And really what I'll do here is just give a plug for talking to your doctors about these symptoms, because that's how you're going to bring them to their attention and can address these various aspects and sort them out. So it's important to let people know if you're having these symptoms. Sometimes people are under the impression that they should only talk to the neurologist about their motor symptoms, and so they kind of hold some of this stuff back. And so I'm encouraging you to openly talk about these things. So cognitive behavioral therapy, as I said, one of the most well-studied psychological interventions in Parkinson's disease and otherwise for depression and anxiety. This slide just speaks to the benefit seen in one of the main trials for depression. The darker blue line showing that over the course of treatment with cognitive behavioral therapy, as well as at follow-up, that people's depression scores were much lower, so they were less depressed with cognitive behavioral therapy. There's been similar results more recently for anxiety. And so this is a mainstay of treatment for some of these issues in Parkinson's disease. And so what I'm going to do now is kind of walk through what cognitive behavioral therapy is and ways that it can help. So going back to our example, so you walk into this auditorium, you're running a little bit late, the seats are filling up, it's crowded, it's kind of chaotic, and you see kind of a beacon of light, you see an acquaintance nearby, kind of coming in as well. And so you look over, and this is somebody you know from other meetings and feel like you've gotten along well with. And you wave to them, and you think they saw you, but they don't wave back to you. And so you're kind of just standing there and have waved to this person and are not getting a response. And so I have you envision this to kind of think about how one might feel in this situation. So what kinds of things, what kind of thoughts, what kind of emotions might come up for you in a situation like this. So I've written some potential things that people might start to think about. Things like maybe you've done something wrong, maybe you've offended this person. Thinking that they definitely saw you, that you're sure that they saw you and then just ignored you. Feeling like maybe your Parkinson's symptoms make people uncomfortable. Maybe you're thinking that you shouldn't have come in the first place, feeling a bit helpless. And then there's sort of the emotional responses that come with that. So feeling nervous, embarrassed, panicky, sad, or hurt. And then the behaviors you might consider. So maybe somebody would consider just leaving altogether, or avoiding talking to people the next time, or maybe not coming the next time. And then there's the physical and motor aspects. So you might have chest tightness, increased shakiness, freezing with anxiety. And so all of these things kind of play off of each other and continue the cycle. And so how might cognitive behavioral therapy approach this? So what it does is it explores the links between these thoughts, behaviors, and emotions, because the feelings and behaviors that one experiences is often due to how a situation is perceived. So, for example, the situation we just described. So one technique is to help people recognize automatic thoughts, so those sort of negative thoughts that may come into your mind, or thought distortions. And often we're not conscious of these things. They automatically happen. And these can be things like catastrophizing, so always thinking of the worst case scenario, all or none thinking, where it's kind of all good or all bad, and people are leaning towards the bad outcomes, or emotional thinking. So despite getting evidence to the contrary, you go with what your emotions feel, as opposed to taking into consideration new information that might speak against what you're feeling. And the goal is really to monitor these things, be able to recognize them, and then restructure your negative thoughts, and ultimately challenge and revise problematic core beliefs. So if you go back, the core belief in the middle is I'm not good enough. So core beliefs are long-standing, kind of ingrained schemas or scripts that we have for ourselves based on early life experience and genetics and these things, and they sort of color our experience. So we go into a situation and we have this sort of negative idea about ourselves, and then we look for information that confirms that, as opposed to trying to look for information that may not confirm that. So we start with one aspect of working with the thoughts in cognitive behavioral therapy. And then there's the behavioral aspect. So if you look, I have the three little circles there with the behaviors, emotions, and thoughts, and really just kind of looking at the interplay of those. So behavioral activation is increasing meaningful activities in life. So whether it's social, exercise, hobbies, just enjoyment. And in Parkinson's, what we work on is a lot of planning for potential obstacles related to symptoms or medication. So planning around on-offs, breaking things into more doable, meaningful pieces, being more flexible, PD-specific programs, and then also working on sleep hygiene, because we all feel better when we've gotten a good night's sleep. And I, again, for time's sake, won't go into too much detail, but these are some of sort of the behavioral approaches. Now, behavioral activation can also be an intervention on its own, but often it's included as kind of a part of cognitive behavioral therapy. And then the emotional aspect. So sometimes there's this idea that emotions are good or bad emotions. Anxiety is a bad thing to have, or depression, but emotions are really there. They evolve to tell us something. Anxiety is there to tell us when there might be a threat in our environment, or sometimes to motivate us. So a little bit of anxiety about giving a talk about anxiety, as I'm doing today, can be motivating to get things done. And learning how to manage these emotions when they come up. So a lot of work around relaxation exercises or breathing exercises or meditation, things like self-expression through the arts, through painting or music or journaling, and how to really work with these emotions when they come up instead of letting them kind of take control of your daily life. Stress management or stressor management, stressors being the situations and events that stress us out, and stress being the personal experience we have of that. And then what I work with people on a lot, or some of our therapists do, is some of the grief related to having a chronic illness such as Parkinson's. So kind of a grief for what once was, or how I used to be, or the things I used to be able to do that I no longer can. And this can lead to feelings of anger or guilt or shame. And so working with those aspects, I think is really important. And so again, just kind of giving a quick overview of how CBT can help, how it works, and some of the elements of it. For the last little bit, I do want to touch on mindfulness, which I think is important and very cool option or practice or intervention. And so sometimes people, you say mindfulness, it's kind of a buzzword. It's a thing you might hear a lot about, but sometimes it's not totally clear what exactly mindfulness is. And so mindfulness is defined as awareness that arises through paying attention, on purpose, in the present moment, and non-judgmentally. So in a sense, you hear the phrase "be here now." So you're being completely in the present moment with whatever that brings up, whether it's positive thoughts, negative thoughts, different emotions, and sort of being with them and allowing them to kind of run through you, and then letting them go in the moment. This is different than relaxation. Relaxation, there's a goal of reaching a sort of calm, tension-free state, where the goal of mindfulness isn't actually to reach some Zen or nirvana state necessarily. It doesn't really have a goal in that sense. It's more just being completely in the present moment. And there's specific mindfulness-based therapies, such as mindfulness-based stress reduction, that are formalized, over a course of time, really learning how to do these mindfulness practices, mindful movement, mindful eating, various aspects of things to address stress. And these have been shown to be beneficial across a whole slew of stress states, illness states, both neurological and otherwise, as well as some I would say developing evidence in Parkinson's disease. So I'll just go through these a bit quickly, but this is an interview, a survey of 5,000 people with Parkinson's. The paper recently came out. And it's the effect of mindfulness in people with Parkinson's who utilize these practices. The first one, the first graph there, is essentially just showing that of all these people interviewed, the ones who use mindfulness felt it would improve their lives or helped a lot with anxiety, depression, tremor, gait and freezing, sleep problems, as well as bradykinesia and dyskinesia. So across the board, beneficial. And so essentially, I think these practices can help everyone to some degree, but in Parkinson's specifically, we see that people feel they help with the whole range of motor and non-motor symptoms. The graph next to it is simply showing that the more you practice mindfulness, the more improvement you get. So everywhere from once a month to several times a day. And the more you do it, the better you get at it, the more it helps with these things. On the flip side, these two graphs are speaking to how many people with Parkinson's are using mindfulness or mind-body interventions. So the blue blocks at the bottom are the most obvious ones, I guess, to look at. Those are people who are not using these things. So physical exercise is quite well used. 80% of people with Parkinson's surveyed use it. And I think that's super important. Exercise is still the best medicine, I think, that we have. But in terms of mindfulness, relaxation, other meditation, 60 or 70% of people have never used these things. Although the bottom graph shows that most of them are interested, but never really thought about it. So that's really a goal of my talk, is to kind of get people thinking about this, let people know it's out there, and give a little primer on mindfulness. This is a slide adopted from Dr. Subramanian with just different mindfulness or mind-body interventions and areas they can help with. And in terms of depression and anxiety, mindfulness, Tai Chi, dance, yoga, acupuncture, of course, exercise. So a number of different options that I think other talks have or will go in more detail about, but just that it's, mind-body practices can look like many things. And so there's options for people to explore to find the best fit. And my last slide, I was going to talk a bit about this, but I think really it's just bringing home the point that if you're experiencing these things, any neuropsychiatric symptoms, anxiety, depression, really talking to the people involved in your team about it. Spouses, family, caregivers can all be super important to helping identify anxiety, depression, track it, monitor it, and intervene to help with it through CBT or behavioral activation. So the caregiver role is extremely important when it comes to these things, and letting your doctors know they're the ones who can make the referrals to mental health professionals to pursue things like CBT, mindfulness. One of my goals, and I think Dr. Subramanian's goals, is really to increase the number of people providing these services, educate people on these so that they're more available to our patients, and so that's a significant goal. But if we don't talk to people about it, then we can't sort of go down the path to getting help. And even physical and occupational therapists, other team members, spiritual people in your church or spiritual community. There's many different aspects of this where it can be helpful, but we need to be able to identify and monitor these things. And so just putting in a plug for increasing our communication about these issues. So I think that's it. And I apologize for the blip in there that slowed us down a little bit. But I guess I can ascribe to my quote. You can't stop the waves, but you can learn to surf. So you can't always change the stressors, the situations that you're in, the things that are causing you anxiety or depression, but you can learn to better manage them. And these are some tools that can be very effective in Parkinson's and otherwise to help you do that. And so I think I will end there. I threw a few resources just in terms of education support around mood and anxiety, as well as some mindfulness-based resources for recorded meditations and things of that sort. So I will finish there.
That's awesome. Thank you so much, Joel. That was a great overview. And a few things that you said really resonated with me. Maybe we can stop sharing so we can have a chat now, and we'll share slides with the group. That was great. Yeah, I mean, I think we're seeing that there's, one thing is, I think that the sort of sense that the mind, the body are connected, and there's practices that you can do in the body that affect the mind. And similarly, there are things with, mindfulness exercises that can affect the body. And I think they're so connected. And I think in medicine, and what one thing that Greg had said, Dr. Pontone, is that, there's sort of the sense of this Cartesian dualism where they're separate. But I think in something like Parkinson's, where so much is, kind of interplaying, I think you can kind of break the cycle of some of the sort of, you mentioned that the sort of getting anxious about anxiety, having anxiety, and sort of the sense that sometimes you're feeling sort of a trigger in your body with like an increasing heart rate, or the sense that, you're starting to feel a certain way with your breathing. And then you sort of automatically interpret it as, I'm going into a panic attack. And then you almost preemptively get there, kind of similar to a pain analogy, where people start to sense pain coming back and almost sort of preemptively get this panic around a pain sort of thing. So I think some of the practices that are helpful sometimes, by checking in with your sort of physical state and kind of being aware, is sort of breaking that cycle, hopefully a little bit, and getting sort of a sense of the body and the mind, I think is sort of very helpful. So I think that's really, really interesting. I think also what you brought up about telling people, I think people sometimes feel so isolated with some of these things, and they think that it's a movement disorder and you're seeing a neurologist and it's a neurological disease, and that it's just pure motor symptoms. I think we've sort of sold the story of Parkinson's in this sort of way, where then the patients sometimes feel like the only thing that's happening to them is their tremor. And really there's this underlying sort of, that's the tip of the iceberg, and everything else that's underneath it, which is sort of these sort of things in the state of the mind, the sort of mood, all of these things are really what's really bothering them and affects their quality of life so much. And they don't even know who to talk to. So I think, something that you said about, increasing awareness and communication also really resonated with me. You mentioned, there's sort of these medications, but I think it's just so nice to see the sort of group of psychiatrists, many of whom you've all mentored each other and connect so well, and really have a respect for each other, and the psychologists that also do this work, which we have, been exploring a little bit more, and sort of the sense that you can use some of these sort of mind-body practices, the exercise, then you can use cognitive behavioral therapy, working with a therapist, and then psychiatrist also can be part of the dialogue, and not just throw another pill into the mix. Sort of you have this whole multidisciplinary team sort of behind sort of the neurologist, maybe supporting us to kind of help with these, and so the patients really need to just understand that this is all part of the disease, and maybe communicating a little bit more, with everyone is sort of very, very interesting and exciting. I think you've really, sort of had a lot of, great comments here. One thing that I think is sometimes a little bit sort of, I think, intimidating is the sort of concept of having to meditate formally as a starting place. And when people are not feeling so well, like, how do you even start? We're going to have one of my mindfulness teachers, Christiane Wolf, come on in a few weeks, and Andrea can link that, and we'll have, she's actually an MD who, as an OBGYN by training, who is actually teaching a lot around mindfulness, around pain and mindfulness and things. So we'll have, some more practice there. But maybe from your perspective, how do you get people to start, maybe, if they're just looking for an entryway to start a meditation practice?
Well, I think speaking to what you're just saying about sometimes having trouble sort of getting going or finding the right fit, first, just to highlight, that was kind of my goal with that last slide, was that meditation or mindfulness doesn't all look like one thing. So there might be a number of different activities or things you can try to find the right fit. Some people, people picture meditation, it's just kind of sitting cross-legged in the same place for a long time or something like that, which, if you have pain issues or anything like that, can be very difficult. And so, there, in terms of yoga or other aspects of things where there might be more movement, walking meditation. So I encourage first to try different things and not be discouraged if the first thing doesn't work out. I think not everywhere, but many institutions have opportunities to do mindfulness. I know at our VA, there's now a new sort of mindfulness center doing mindfulness with veterans. So I would look into what's available around to kind of get started, because having some guidance definitely can get you going. But that's also why I include some online resources in this in this day and age, especially in the pandemic, there's actually a lot of online virtual resources as well that people can tap into. And then the last piece I would say is to start small. You don't need to jump in and be an expert meditator right away for an hour at a time. You can do little bits at a time, and it's a practice. Like anything, it takes practice. So it's not something you're going to just get right away, but you start to incorporate a practice, and you get better at it over time.
Yeah. And tell us a little bit about what you think the breathing sort of may lend to as well in the picture sort of, and do you have resources for that as well? Or, I mean, like when you're talking about, so you sort of, it sounds like you give people some resources and maybe they can try a few different things and kind of, see where it lands. And maybe for some types of people, breathing may be helpful. Like, tell me, like anxiety versus depression versus apathy. Like, do you have a sense of when you're looking at a patient, what types of things to try for these different types of symptoms, or they all sort of help for all of them?
In some ways, I mean, for anxiety and depression, we know that cognitive behavioral therapy is sort of a tried and true intervention. And so often I will start there in terms of the treatment aspect of things for anxiety and depression, because it can be very effective. The mindfulness piece, while there are also mindfulness-based psychotherapy, formal interventions, that can kind of be done on one's own time, or in addition to therapy, or in addition to whatever else they're doing. And so some of that is kind of gauged off of interest or helping people get interested. But it's a conversation I have with each individual to kind of tailor what might help. I think in anxiety, using this example, given all the physiological symptoms, given how common it is, working on more sort of relaxation, breathing techniques that might be easier to incorporate day to day is something that I often try to do. But mindfulness and these sort of breathing aspects and things, in some ways, they're the opposite of anxiety. Anxiety is very much involved in being, your brain stuck in the future or the past, worrying about what's going to happen. And so trying to help people realize that if they can be in the present moment, that's almost incompatible with having a panic attack or anxiety in some ways, not completely, but so I try to help educate them a bit and then support whatever path they think works for them.
Yeah, absolutely. So when we talk about CBT, is it really sort of one-on-one? Is there a way to do it in groups? Is there a way to do the CBT online? Can you tell us a little bit more about that?
There's many forms of CBT over the years, and kind of it can be tailored in a lot of ways within CBT itself. There are definitely group CBT interventions. We have some CBT groups for depression and things like that here at the VA, not necessarily Parkinson specific. And I think there is more research happening, because part of the trouble is we need more people providing this, and groups can help kind of get a bunch of people together, support each other, as well as everybody get the treatment. And so there's more work being done on group interventions. But there's CBT as a group format is definitely out there and can be very effective as well. And just to touch on the mindfulness-based stress reduction, by design, most of those are group intervention. So, and there's kind of that aspect of learning from one another there as well.
Yeah. I went through mindfulness-based stress reduction class at our VA with some very gifted teachers, and it was transformational. I think just to realize, and we had some mindful movement, some yoga in there, some walking, a lot of nature. So we spent a lot of time in the garden that was behind the room at the VA, just sort of, taking in, I've said this before, the five senses kind of walk, where you're, smelling flowers, maybe in a garden, feeling the grass under your feet, looking at the beauty of, what's right in front of you, and sort of just kind of grounding to that space. And I think there's simple things. People are like, can we try a couple of things now? I think we won't have the time, but these sort of simple practices where you're just, in nature doing these things. There's some gratitude practices sometimes about 3 things that you're thankful for now. And so even if you're in tremendous pain, you can still sometimes find ways to sort of think about sort of the environment or whatever you're in with your body and sort of feel something pleasant, even if it's, feeling the breath kind of entering your breath passageways and feeling where, the sort of breathing impacts you and you're, noticing kind of different sensations. So I think, there's a lot of things that are out there, but I think, I agree with you, sort of getting out of the sort of thinking about what you could have done in the past to change things or what's going to happen tomorrow. I think so many of us are like that day to day. And I think sometimes just, I told you that we had a big gas leak in my neighborhood, and we ended up, having very much uncertainty this past weekend about, electricity and internet and all kinds of other things. We weren't sure when this was all going to end. And my kids were like, when is this going to end? When is it going to end, Mom? And so I just took them out to nature, and we started to just notice the flowers and go put our feet in the sand a little bit and just sort of try to change up the scenery a little bit. Sometimes just I think resetting can be tremendously helpful. People are asking a little bit about prayer and religious stuff, and also maybe music, given your music background. Maybe you could teach us a little bit about how those practices may also tap into the mindfulness stuff.
Yeah, I mean, I think those practices, I again, in the sense of grouping them with some of the others, anything that you can find that I think, as we were just talking about, that sort of keeps you in the present moment, that keeps you there with the music, and having that stimulation from the music, in terms of hearing it. Or else, in terms of prayer, sometimes people much prefer something along those lines that has that kind of spiritual connection aspect to it. And so, in terms of the benefit, I think they're in the same realm, really, of that goal of keeping someone in the present moment. But also, the nice thing about music, for example, is in some ways, if somebody's been listening to music throughout their life or has favorite songs or whatever it is, it's not something you need as much practice for, to kind of turn on some music and have that be something you connect with to try to stay in the moment. So if that works for people, I think that's a great way to go. And same with prayer. If that's something that you do in your life, it may be an easier thing to kind of transition into some of these present moment practices that can be helpful.
Absolutely. Well, I think
more meaningful as well.
Yeah. Maybe Joel, I know that you've been taking care of patients, and we've talked about this a little bit through the pandemic, and we're sort of emerging from some things. One of the things that you mentioned was when you showed the sort of different states of anxiety, was sort of the sense that sometimes there's these avoidance behaviors, and people have felt, sometimes with the Parkinson's, even before the pandemic, that there are reasons maybe not to be in public, maybe not to connect, these sort of things. And so people end up sort of more isolated. Could you speak a little bit to your sort of, because I think you sort of indicated some of this with the slides that you showed, and even that the sort of case study that you presented, where somebody comes to an event and then feels certain ways, and you sort of then sometimes feel internally like maybe I shouldn't go, or I should just avoid this in the future. Tell me a little bit about your take as a psychiatrist working in the pandemic with our patients, and the role of social connection. As you know, it's been a passion of mine to sort of speak about this and learn more about this. Tell me about your experiences.
To start with, I think my experience is kind of we're all in the same boat. I think it's been really difficult for everybody across the board, and even more so if someone has an illness or issue that already was keeping them from engaging in some activities and things like that. But it's been very difficult. I think that it's just kind of thinking about things from a little bit of a different angle, or thinking about changing resources. I mean, that's why something like this, virtual stuff, although it may not be completely the same as in person, using what we have to really engage people and try to engage. I think the number of resources has sort of skyrocketed in line with the pandemic because of the situation. And I think, it's led to kind of, even at home, trying to figure out, you you used to go to a Parkinson's exercise class. How do I now start to do those things at home? So again, I think we're all kind of trying to figure that out together. But some of the things I'm seeing come out of it are good advancements in that sense. And I think, again, talking to the people you do have on your team about these things to help kind of problem solve in terms of figuring it out, whether it's your caregiver, spouse, doctor, to maybe learn about resources and come up with ideas. And I'm learning a lot from the people with Parkinson's I see about things that are out there and things people are doing. And so, yeah.
Yeah. One last, we have a few moments just to end here. One thing that I think is a big deal in anything mental health related, and since we're going into, mental health awareness month, is stigma. And, I think that what I'm trying to do with, connecting here with all of you who are, friends, and we work closely together, trying to help solve this problem, is to help our patients and people living with Parkinson's and the people that love them to understand that this is very much a fully connected disorder. So the fact that you're seeing a psychiatrist and they're modulating chemicals that may not be exactly dopamine, and the fact that you come and see me and I'm modulating things that maybe more in the dopaminergic realm, that it's all just one kind of continuum. Could you speak a little bit to the concept of stigma and also your concept of the mind and body now that you've been doing this for a while?
Yeah, so I think as a psychiatrist who's working with people with Parkinson's or in that realm, part of what I've hoped to do, and I've seen even in the past 10 years, seen great changes in terms of dealing with the stigma, even within the medical aspect of things, of everybody viewing this as a mind body, neuropsychiatric, all these aspects that they're all important and they're all part of the illness. So even among medical providers, as well as the lay public and patients. So I think we're making strides towards it. I think education obviously is a huge part of that. And as I said, I think learning from the people we see, our patients as well, has been very helpful for all of us. So continuing to have those kind of interactions, as well as more broadly, with different organizations and things like that. But I'll just say that Parkinson's specifically, the reason I got into it, I continue to see it every day, that this mind-body aspect it's across the board. And I don't necessarily even view it as kind of subspecialties. I view it as a team where we're all taking care of, different domains of the illness, but it's kind of a team approach. It's not, oh, I have to go see a psychiatrist, or, oh, I have to go see a dietitian. It's everybody's fills some role and a part of helping with this. And so that's kind of my approach. And so trying to get that word out is, I think, a goal.
Absolutely. Well, it's been so great to get to know you over these years, Joel. And, I think we've all sort of gotten to be like one big kind of happy, crazy family in our own ways at the VA side, as well as the rest of, sort of the group globally. And I know that you've worked with the Queen Square, the King's College gang with Ray, and the non-motor kind of gang. And I think it's, I think we're continuing the dialogue. So I look forward to seeing, as we hopefully emerge from this pandemic, how we can continue to work together and hopefully normalize, I think, these conversations a little bit more and help patients to realize that they can, bring these symptoms forward, and that we can hopefully help them in not just, I think people are sometimes fearful that if they talk about some of these symptoms, that their doctor is going to put them on one more pill, which they want to kind of avoid. But I think sort of the dialogue of having these sort of ways to learn, about coping mechanisms with these mind-body approaches and thinking about these other sort of concepts, as you've illustrated, I think are hopefully going to be very helpful in moving forward. And so I look forward to continuing the dialogue. Thanks so much for spending the time with us, and great slides. Really enjoyed seeing them, including the one that you modified of our chapter. I think we might need to update that given all the recent advances. And I think we're getting more and more evidence that this stuff works. So thanks so much, Joel, for spending the time. And Andrea, I will hand it back to you to wave us out.
Yes, thank you.
Thank you, everybody. Thanks for having me.
Dr. Subramanian. We always end with a goodbye wave. So invite you to turn on your camera and take a look at everyone out there in digital land, Dr. Mack. We really appreciate you sharing the slides and sharing the presentation with us. And thank you to all of you for your excellent questions. Bye
Bye,
now.
guys. Thanks. Take care.
Bye-bye. Thank you.